We don't train for perfection. We train for chaos. Because when a patient rolls through the door with their face missing, and I mean actually missing, not just damaged, your textbook algorithms don't mean anything if you can't stay calm enough to apply them. I'm Ross Orbit, and you're listening to Loud and Clear EMS Guiding Principles. This episode was recorded on site at FastCan, where I sat down with someone who's forgotten more about critical care transport than most of us will ever know. Allen Wolfe is the Senior Director of Education at LifeLink. He's a critical care nurse with decades in the field, and he has literally wrote the book on critical care transport. Allen gave a presentation on one of the most challenging scenarios to manage in the field or in the ED, and that's airway management in the setting of severe facial trauma. The thing about facial trauma is it's graphic, it's distracting, but we need a way to block that out and move forward. Allen walked us through a real case he was involved in, a self-inflicted shotgun wound where the entire mandible, nose, and midface were just gone. Looked like hamburger meat. And this patient was conscious, coughing, spraying blood everywhere with every breath. So what do you do? Where do you even start when the anatomy you've memorized just doesn't exist anymore? That's what we're diving into today. Allen breaks down the decision-making process in these high-stakes situations. When do you scoop and run? When do you secure the airway? How do you manage an airway when you can't bag the patient? What about when your pilot is sitting right next to this horrific injury and trying to fly you? We talk about the basics that matter: PPE, assessment, understanding what a difficult airway actually means. We even get into the weeds with the Monroe-Kelley hypothesis and discuss some cerebral perfusion. But more than that, we talk about staying calm when everything around you is chaos, about making decisions under pressure, about knowing your backup plans, A through Z, before you need them. Look, this is the stuff that separates amateurs from masters. And that's exactly why we created the Paramedic Confidence Builder course. We dive deep into managing and leading these stressful situations through deliberate practice. Because you don't rise to the occasion, you fall to the level of your training. The course teaches you how to become a calm and competent provider within the chaos. The one who doesn't freeze when the face is missing. The one who has a plan and executes it. If you want to learn more about the Paramedic Confidence Builder course and how deliberate practice can transform your clinical confidence, head over to our website. We'll drop the link in the show notes. All right, let's get into it. Here's my conversation with the legend himself, Allen Wolfe.
Loud and clear, number 2, go ahead.
Allen, thanks so much for joining us. This is the second time on the podcast. We rebranded to Loud and Clear now. I'm Ross Orbit, and I just listened to you talk about facial trauma and the difficulties it poses in airway management here at FastCan. So first and foremost, what defines severe facial trauma in your mind?
The facial injury classification scale created by Dr. Lefort out of obviously France, put it into 3 different categories. One meaning just your upper mandible. Those are usually we kind of see sometimes in the sports injuries, kicked in the face in soccer, that kind of thing, and breaks your upper mandible. But usually the 2s and the 3s of Lefort's are the ones that are more dangerous. A 2 meaning it's the mandible and includes your ethmoid bone, which is the bridge of your nose kind of is involved, and have a floating nose, but now your mandible, your nose is broken, creates a bigger issue for that one. And then Lefort 3 includes I call it your eye socket, the orbits that sits, that holds your eyes together. So it's not free floating, your eyes are not floating around, not something stable like that. And you think about the force that's used to destroy your bones in your face, has to be pretty powerful, and that creates potential for injury to your brain, or creating a injury to your cranium that causes a CSF leak. And so once a CSF leak has that communication to the outside, which can lead to meningitis and infection and all these other things besides other parts of traumatic brain injury.
Yeah, and to highlight some of these challenges, you walked us through a real life case that you were a part of.
Yep.
Can you just set that up for us?
Yeah, this was a young man who was a single gunshot wound to the face, self-inflicted, at his home, I guess dealing with severe depression, put a shotgun under his chin and then pull the trigger with his toe. But what happened commonly with shotgun blasts like that, when you do that, people don't anticipate the gun jerking, and that's why the front of his face was missing, but all the other portion was intact, and he kind of missed his brain. And so when we're getting a single gunshot wound to the face, you think, oh, just one got, single bullet to the head, but shotgun blast obviously is different. So all the soft tissue is missing. So when he rolled in the door, had a blood pressure, I think I would just say around between 110, 120 over the 70s and 80s. And his heart rate was in the 90s. His respiratory rate was about 24 to 28. And his sats were like 92, 93%. And he was just coughing, clean his own airway himself, and so most people would see that in the scene. And I always call those, I won't say distracting injuries, but they're horrific, and distracting meaning it is distracting. You can forget this, like the C-spine. Like I said, he came in with no collar.
Yeah.
That's the last thing they were thinking about, was that, he could have had a neck injury, but the other part that was more graphic was just the open face and the potential for bleeding in the airway piece of it. And so those are graphic but treatable, but we see them more common than you think, these days.
Yeah.
So.
Yeah. To kind of describe that, essentially the entire mandible was missing, including his nose. His midface was just open and looked like hamburger meat.
Yep.
And that can just be so distracting, like you're talking about. And in your mind, you're like, anatomy's gone. Where do I start?
Right. And it's start with the basics, one, PPE, protect yourself, because there's a lot of blood going there. And so we're talking, we're not, all of us don't wear goggles all the time. Now's the time to put the goggles on, because there's blood flying.
Yeah, as he's coughing, soft blood, it just
implement his own airway. It's getting on you now. And so whatever PPE you can put on, especially goggles and a mask for sure, and gloves around to protect yourself. And then to start with the airway, get a good assessment of your airway. And so with this guy, I said his sats were 94 and he's breathing fine. Technically his airway's okay. And so that would be if you were on the ground and your travel time was short, there's nothing wrong with scooping and running and just gunning it to the ED to get wherever you're going.
Yeah.
Because when you get there, you can say, well, he ain't dead, is he? Right?
Yeah.
His sats are decent, and he's breathing on his own.
Yeah.
So somebody else could decide what to do. But there's other cases when you have to make a decision if there's a longer transport time or if you're in the aircraft, right? And so for some of us in air medical, our aircraft are different shapes. And I didn't bring on this on the stage because my clock was ticking.
Yeah.
But in air medical, if you have in an aircraft where the patient sits next to the pilot, remember, if this somebody with their face off, and this just like this, they sit like this, just like me and you are sitting here next to you. If you're a pilot, and pilots, remember, although we hang out with them a lot, they're non-medical. They just hear and say stuff and just repeat words we say. Yeah. But when they have to fly an aircraft and then they look over, like, what the hell is going on? So I would say, you don't want your pilot distracted when he's got to fly, when that really graphic thing is sitting next to him. So you can take that into account. So in those instances, the airway most likely should be handled ahead of time. The other piece of it to think in critical care is what's going to happen down the road. Will this patient be intubated eventually? And if you were someone say, you know what, this is way outside my pay grade, I'm gonna do the best I can. Like I said, there's nothing wrong with bringing someone in, breathing on their own sats, and just using this blow by, just put this oxygen in the face. Because for this particular patient, there's no way to put a mask on the face, no way to put a non-rebreather, no way to do passive oxygenation. All that checklist stuff that Dave O'Bear talked about earlier, this doesn't apply because this patient is different, right? This patient is different. So
yeah, aside from the severe facial trauma, the obvious,
right,
what in your mind makes this a difficult airway?
But I think the difficult part is, can I bag the patient, right? When all hell breaks loose in pre-hospital on the ED, first thing we all reach for is the bag, right? And so if I'm reaching for the bag on this patient, if you say this guy all of a sudden went apneic, it would have been total chaos because the mask is not going to work, because there's no way you can gather the bone that's in the pieces and then the soft tissue to ventilate the patient especially flat. Flat is going to just cover the hole. You sit him up, it may do the same. And so you need this guy to continue to breathe to manage his airway. The bag's not going to work. So the ambu bag is the thing we all fall back on. So I would say to anybody when looking at somebody's airway, to say, if we give this person drugs or something happens where he's apneic, am I able to ventilate him without with a BVM? Is nothing wrong with bringing someone to the ED, just bagging them. Well, he ain't dead, is he?
Yeah, absolutely. Yeah.
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 Right.
Yeah, for sure. So factors, you have to take this patient's airway, and you guys were in the emergency department. He's going to need an operative intervention,
Right.
needs his airway taken at some point, or maybe you're in the field and you decide the transport, I have to take his airway, or he loses his airway and suddenly you got to do something. What are your first steps? Walk us through how you did that.
For this particular, yeah, we roll the door. The first thing is to make sure he was sitting up at the highest way possible. Why? 50% of your lung volume is lost lying flat, right? So we didn't want him flat, wanted to breathe. We
Not only that, he's bleeding. So you let him flat, he just has blood pooling in the back of his airway too. Yeah.
Exactly. And so let the patient sit in a position of comfort. And he was comfortable just sitting at that 90-degree angle, able to control his own airway. After that, IVs quickly, think about some kind of what we're going to do for something. We need access and resuscitation in the event that he became apneic or he became cardiovascular collapse, right? So we got airway, have not done airway, we assess the airway, we assess the breathing. He's breathing on his own. Next thing is the line. And then the other stuff is the disability. C-spine, none of us even, that wasn't even priority. Not if attending.
Yeah.
Nobody even thought, what about a C-spine?
It's so true. You mentioned the stat that in penetrating neck trauma, the C-spine is injured only 3 to 5% of the time. Right. And that's in GSWs. When you talk about stab wounds, it's like 0.1% of the time. So I agree that the C-spine or a collar is more likely to inhibit your care, mask injuries, than it is to help. And even the recent trauma guidelines, even if you really legitimately are concerned about a C-spine injury, but you need to take somebody's airway, they recommend taking it off the collar for the intubation.
Very true. Very true. Very true. The other thing too, that I would think the collar may help sometime is once you got the airway secure, just kind of hold everything together.
It's true. Could probably little support that's lacking right now.
Dude, exactly.
So what did you do next?
Once we got the lines in, the decision, the idea to intubate him face to face came from one of the medics. Says, the flight medics was watching, said, why don't we just intubate him face to face, And so the physician says to everybody in the group, and as he has he put an oral airway, not in, but he put the oral airway to open the hole up wide so we can breathe. The system.
Yeah, I saw that. He was literally looked like holding that oral airway, pushing the tissue down so the airway was open.
Yep. And he just helped him while we were running in circles to get things going. And so he says out to everybody, especially, nursing, who was usually the group has the drugs, don't give him anything that would cause this guy to stop breathing. Does you understand? He made that clear. He must have said it 3 times. So that anybody give anything, because he was concerned somebody, he needs a little fentanyl. Oh, he needs a little Versed or something. And then of course a respiratory arrest or something. And so,
that what little structure is holding that airway open, suddenly paralyze that and it just collapses.
Yep. He didn't want any drugs given. And so he was getting a plan. And then the attending was verbally thinking out every single thing that he was thinking to the entire resuscitation team. You go, okay, I don't want to crike this guy here. I want to do a more formal trach in the operating room. So let's take the advice of the flight paramedic here and let's intubate this patient. And so that was the decision, was to intubate him doing the face-to-face technique, the inverse intubation procedure.
Yeah. I love that process of the person running this resuscitation talking out loud to the entire time. So everybody knows where his mind is. I don't want his airway to collapse. I think we need to take the airway here so I can do X in the operating room. I'm not sure I'm going to be able to crank him because looking in the picture, his entire thyroid is gone. So how do you find that membrane? Is a whole nother challenging piece.
Right. And I think too is for a leadership part on that, it was great for the physician. And weakness is not saying, you know what, I don't know what to do. I'm just going to say everything that's coming through my mind. So maybe someone else who want to say something, is exchange, may say something of value. And that's when the thing, the medic says, why don't we intubate him face to face? That kind of thing. And so I find it's a example of strength for somebody to say, all right, I'm just telling you what I'm thinking I'm doing here, and we're going to get through this. And so I think it was pretty valuable.
So how did they intubate this patient sitting up face to
Right.
face?
So had him up at about almost a 90-degree, high 45-degree angle. We use a Mac blade, to do that. Mac blade goes in your dominant hand, non-dominant hand, your dominant hand, and you're pulling down toward the feet, so you're not using all the force you would if they were laying on their back. It's much easier to intubate somebody face to face. And so the suction was still applied with the Mac blade in, you're pulling down, and just got a 8-size ET tube, had a stylet in it, and just put it right down the tube. Technically, he didn't really need a stylet if he didn't want it, because the hole was just right there. We hit it,
Yeah. So it's once you pulled all that tissue away.
right there,
Okay.
sitting right there. So it was easy. The cords were there, as a question somebody asked.
What medication did they use to?
He's got only ketamine only.
Yeah.
Right. And so I think he had 50 of fentanyl, maybe that, and ketamine, but that was the only drugs he gave. He did give him, however, when he was just about to do it, he gave him Cedar spray in the back of his throat, thinking, what is that going to do? Yeah. But if that's what you want to give, Cedar spray to kind of deaden it, kind of do it. But he wanted him to still breathing for the whole process. And so that goes into, just the delayed sequence intubation. So just drug assisted. And so that's where we're able to do it and get the tube in.
Yeah. Yeah. And then they pass the tube and he immediately starts coughing.
Right.
Which can be a clear sign that you just irritated the vocal cords and their reflexes to cough.
Right.
And then what'd they do after that?
And what you didn't see on the video is you never saw anybody put end-tidal CO2 on there. Another distraction. Everybody's running around and you're just taking, it was direct visualization. I saw it go into the thing. Yeah. And that's really don't get me wrong. End-tidal CO2 is number one, is the gold standard. It should always be, it'll be done. But when we doubt the end-tidal, where do you go to? Go to direct visualization. Yeah. Then they use direct visualization. Then think, no one ever thought, where's the O2 on this thing? The end-tidal CO2. Yeah. So that wasn't shown at all. But once we got that tube in, the next thing was, okay, we're finished, because he was basically vital signs were fine. Let's take him to the operating room. And so that's where the group decided, okay, let's go to the operating room. Yeah. Anesthesia, who came up, in the case, who witnessed the whole thing, they didn't participate when the going was rough. It was watching, comes in, and then he's determining how do I hold this airway and get him downstairs. Now you can use what's known as a lasso technique, which is basically taking a nasal cannula, creating a lasso, putting that over it, and then tying it tight that way, and then cut those little things off and wrap around the neck. I didn't say that up there. I didn't say that. All this stuff I think about, I thought right here.
That's why we're here.
That's how the best way to secure that. You can't use a commercial device. If you notice on that.
Yeah.
Excuse me. Yeah. And so that's anesthesia. That's what anesthesia was thinking. How do we control it for transport to the OR? And so what he decided to do was pretty smart. I'm going to shove it all the way down to the tip here and push it down the right main stem as we go through the halls to get to the operating room. And so what that does is that when I get to where I'm going to OR, I know it's in one spot. Yeah. It's in the right main stem. The only thing I have to do now back is pull and bag until boom, they both come up, and I do my assessment and listen to both sides, and I have lungs bilaterally. And so, which was pretty neat. Yeah. Thought. Yeah. How to do that.
And then after they stabilized him, they put a trach in. He was finally able to go to CT scan. Yep. And at that time, they found pneumocephalus, or air, in his brain. Right. Tell me, what is the Monroe-Kelley hypothesis, and why does it matter in this case?
Monroe-Kelley hypothesis means that you have three things in your brain. We all have. We have blood, we have brain matter, and we have CSF. Those things have equal volume, meaning matter has the bigger piece of volume, about 80%, and the other two are 10%. When any one of these increase, just say whether the tissue swells or your CSF increases, like encephalitis, what it's called, encephalopathy, any of those things increase, the other two have to decrease based on the principle that your brain is an enclosed space. Now, there's something called CPP, which is cerebral perfusion pressure, meaning that you need a certain amount of blood pressure to push blood through that particular, that swollen head, right? And it's based on your mean arterial pressure, right? So if you have just a regular manual blood pressure cuff, that third number that sits there, a lot of people don't look at, that's what we're talking about. Yeah. So if you take that, and I always say use 20. 20 is probably the mild number for increased intracranial pressure. Normal is probably about, I would say, 8 to 16. And so you say 20, Just use 20. Let's assume everybody has 20 when using a traumatic brain injury. So if I take my mean arterial pressure and let's say it is 90, then I minus 20, and then that minus 20 gives me 70. My CPP is 70, which means that's pretty good. I need to keep it 65 or greater. 70 is fantastic. Other people would say maybe even 60, but the brain needs to be perfused. And so as the pressure in my head gets higher, the swelling from that traumatic brain injury, my blood pressure can't be dropping. It needs to go higher. And so you may have to do more volume to raise your blood pressure, using some kind of vasoactive drug to increase your blood pressure to perfuse your head, specifically if it's isolated head injury. This was an isolated head injury. This was Airway. He's lucky. But we have patients with isolated head injury. That's the goal, is you have to perfuse the brain, and that may involve increasing the blood pressure by, some people call it HHH therapy, keep them hemodilutional, hypodynamic, and another one's blood. What that one's called, the H on that one. So just giving them
Hypovolemia.
Yeah.
Got it. Yeah.
That one, dude.
Yeah. So that's why hypotension in the setting of traumatic brain injury is so detrimental.
Yep.
Yeah. Because you're not perfusing your brain if you don't have that CPP.
Yeah, dude. That's it, man. That's it. Absolutely. Cool.
Well, the legend, Allen Wolfe, thank you so much for sitting down.
Stop it.
This was great. Yeah. This was fun as always. I always enjoy chatting with you.
All right, dude. Thank you so much, man. Appreciate you, guys.
Alan just walked us through one of the most challenging airways you'll ever face. But here's what I want you to take away, because it's not about memorizing every step of a Lefort classification. It's about having a decision-making framework that works even when the textbook doesn't apply. So here are your guiding principles. Write these down, tattoo them on your brain, whatever it takes. Principle 1 is protect yourself first. Before you do anything, PPE, goggles, mask, gloves. I know it seems obvious, but when blood is flying and the patient is this graphic, this is the step people skip. You can't help anyone if you're suddenly trying to wash blood out of your eyes. Put the damn face shield or glasses on. Principle 2, ask the critical question. Can I bag this patient? This is your airway decision tree. If things go sideways and this patient stops breathing, can you effectively ventilate them with a BVM? If the answer is no, like with severe facial trauma, you need a different plan. You need to know this answer before you give RSI, before you make your move. Principle 3, scoop and run isn't failure. If your transport time is short and the patient is maintaining their own airway, there's nothing wrong with getting them to definitive care fast. You don't get bonus points for doing a procedure in the back of a moving ambulance when the ED is 3 minutes away. The goal is a living patient, not a highlight reel. Principle 4, consider what happens down the road. Will this patient eventually need to be intubated? If you're in a long transport or aircraft, if the patient is sitting next to your pilot, if the injury is progressively worsening, these factors change your calculus. Think ahead, plan for deteriorations. Principle 5, mentally simulate. And here's your homework. Go through your mental simulation right now. Close your eyes. You roll up on a patient, severe facial trauma. What's your first move? What's your second? What's your backup plan? What's your backup to your backup? If you can't answer those questions immediately, you're not ready yet. Think through this scenario until you can. If this episode resonated with you, if you want help to become the provider who stays calm and is prepared for these situations, head over to our website, check out the Paramedic Confidence Builder course. That's exactly why we built it. In the course, we cover decision-making under pressure, scene leadership, managing the chaos, building the confidence that comes from the type of preparation you put in, not just luck. We talk through these scenarios using deliberate practice and mental simulation so that when the call comes, you're not fighting an uphill cognitive battle to figure it out. You're just executing. Links in the show notes. Head over to the website and learn more. Remember, you don't rise to the occasion. You fall to the level of your training. So train better. I'm Ross Orpit. This is Loud and Clear. Stay safe out there.